Students, today I would be taking a lecture on open bite. We would be discussing the lecture under the following contents. Now, before starting the lecture, I will first like to put a light on what we call as occlusion. So, as we all know, occlusion is nothing but when the maxillary and the mandibular teeth are in contact with each other during mastication or at rest is called as occlusion. Any deviation from the normal occlusion is called as malocclusion. Now, malocclusion can be classified into various planes, that is a transverse, sagittal and a vertical plane. So simply we can say that open bite is a malocclusion which occurs in a vertical plane. According to Daniel and Sub-Tanley, any deviation in the vertical relationship of the maxillary and the mandibular dental arches, which is characterized by a definitive lack of contact between opposing segments of teeth, is called as open bite. Moyers stated that open bite is nothing but localized absence of occlusion while the remaining teeth are in occlusion. Now, we will see that how the open bite is classified. It is classified according to the location and according to the cause. Depending upon the location, open bite can be classified into anterior or posterior open bite. Whereas according to the cause, it can be divided into dental or simple open bite or a skeletal or a complex open bite. Now first we'll see according to the location, anterior open bite. Anterior open bite is nothing but absence of a contact between the maxillary and the mandibular incisors in centric relation. Or in better terms, we can say that it is a absence of the vertical overlap of the incisors. Whereas posterior open bite is when there is a lack of contact between the posterior teeth, then it is termed as a posterior open bite. Now we'll come to the causes. Dental or a simple open bite occurs when the basal skeleton is normal and the open bite is confined only to the teeth and the alveolar processes. Whereas a skeletal or a complex open bite results from a skeletal dysplasia so severe that the alveolar process cannot cope to maintain the occlusal stops. Now we'll come to the etiology of open bite. Now open bite is multifactorial. It can be caused due to n number of factors. So we'll just go through one by one. The first one is tongue thrusting habit. Now tongue thrusting habit occur in children who have a tendency to place their tongue anteriorly while swallowing. So in these kind of patient, open bite is seen. Whereas it is also seen in small infants who are having a habit of thumb sucking or digit sucking. In these cases, open bite can be seen. Whereas it is seen in patients or infants who are having a mouth breathing habit. Open bite is seen in patients who are having a macroglossia or a large tongue. In these kind of cases, open bite is generally seen. It is seen in patients who are having growth disturbances, as well as in patients who are having a lack of alveolar development. Now we'll see the clinical features of open bite. First, we will see what are the soft tissues features. That is, it is seen in the profile of the Patient is generally convex. The lips are incompetent. The patient is having hypotonic upper and lower lips. The patient is having a retruded chin and a tendency of a long face syndrome. These are the soft tissue features. Coming to the dentoalveolar features, there is a infra eruption of the upper and the lower anteriors. There is a extrusion of the posterior teeth. There is a tendency of proclination of the maxillary anterior teeth. Reverse curvosp is seen, as well as gingival inflammation with the upper and the lower anterior teeth is also evident. Coming to the skeletal features, the patient is having a underdeveloped upper and lower arches due to the counterclockwise rotation of the maxilla as well as the clockwise rotation of the mandible, or a combination of both of these, which uh, which is also one of the contributing factors in a skeletal open bite. The facial planes are also convergent. The ramus length is reduced. Palate is placed downward. High Frankfurt mandibular plane angle. Anterior facial height is greater than posterior facial height in an open bite case. And lower anterior facial height of the patient is greater than the upper anterior facial height. Now we'll come to the treatment of the open bite. In treatment of open bite, various factors are should be seen, and according to that, the treatment must be formulated. So first one is the first and foremost is the removal of the abnormal pressure habits. If the patient is having any pressure related habits like thumb sucking or tongue thrusting, then these habits should be eliminated in the first place. Second comes the growth modification. If the patient is growing, then various myofunctional appliance therapy can be given to the patients. Then posterior bite planes, myofunctional therapy, as we already discussed in that, box elastics, and finally orthognathic surgery. So we'll see one by one. In the treatment of open bite, first is removal of the cause. If the patient is having any deleterious habits, then the patient should be freed of that habit. In case of thumb sucking, the patient should be given a thumb restrainer so that the patient doesn't indulge into the habit. It should be tied to the patient's hand in this way so that the patient is not able to indulge into that habit. It also acts as a reminder to the patient. Then we can use a chemical approach in which bitter tasting or foul smelling preparation is placed on the thumb so that the sucking becomes distasteful and the patient doesn't indulge into the habit. Various medications can be used for the same, that is a pepper dissolved in a volatile material can be used, or quinine or asafoetida, which is available in our household, can be used and applied to the patient's thumb so that the patient doesn't indulge into the habit and the habit is intercepted. Then various appliances, removal appliances and fixed appliances can be used in the patient depending upon the compliance of the patient. If the patient is compliant enough, then removal appliances which like Holly's appliances with tongue spikes can be incorporated in it, as well as tongue crips can be incorporated into the Holly's assembly and can be given to the patient. If the patient is not that compliant, then in those cases, fixed appliance therapy can be used, in which soldered transpalatal arches and lingual arches with palatal crips can be incorporated in the treatment plan. Myofunctional therapy, skeletal anterior open bite can be treated during growth using functional appliance like FR4 Frankel appliance 4 and a also vertical pull headgear which chin cup can be given to the patient if the patient is having a skeletal open bite. So myofunctional therapy works like wonder in a growing patient. If the patient is in a adulthood, then in those cases fixed appliance therapy need to be done. In cases of mild to moderate open bites, it can be successfully planned with fixed mechanotherapy in conjunction with box elastics. Or if the patient is having a severe or a skeletal open bite, then in those cases, if the patient is an adult, then it is best treated by using surgical procedures involving the surgery in the maxilla as well as in the mandible to achieve a proper and normal occlusion. So this was a small lecture on open bite in which we have seen what are the types of open bite, what is the etiology of the open bite, and the treatment, how you will treat the open bite. Open bite cases are easy to treat but difficult to retain. So always remember one thing, that retention is a very important aspect in open bite. So I will end my lecture hoping that I have put some light on this lecture of open bite, and thank you everyone for your patience listening.